Well, I'm going to be speaking about pelvic floor imaging. My disclosure is that I have received support in research from GE Medical Systems. In discussing the topic of pelvic floor imaging for disorders, I'm going to be covering the following topics. They include normal sonographic anatomy of the female pelvis using the transperineal approach, sonographic appearance of suburethral slings and mesh, abnormal sonographic conditions which may cause urinary dysfunction, sonographic appearance of postoperative complications after surgery, and then finally I'll discuss the role of MR versus ultrasound in the imaging of pelvic floor disorders. Well, pelvic floor disorder imaging may be one of the fastest growing areas today. And the reason is because we have an aging female population. About 50% of postmenopausal women have symptoms of pelvic floor disorder, and the lifetime risk in the United States of at least one surgical procedure in a female is about 20%. And so as a result of all this, it's been estimated that the imaging of pelvic floor disorders is projected to increase as high as 45% in the next 30 years. The clinical factors relating to pelvic floor disorders include the ones that I list here on the slide. And the overwhelming factor is that of being a female. Over 90% of the patients that you will see will be female. And so, unfortunately, that is something that has come about by a combination of factors, including the fact that we, of course, have problems with having multiparity and some of the other risk factors you see here. So again, other risk factors include increasing age, increased BMI, multiparity, decreased estrogen and menopause, and poor collagen. Pelvic floor disorders, of course, are caused by weak pelvic floor muscles and supporting structures. Well, there are two clinical presentations for pelvic floor disorders, and they include stress urinary incontinence and pelvic organ prolapse. Patients who present with stress urinary incontinence complain of leakage of urine during things such as exercise, coughing, laughing, and straining. Whereas those patients who have problems with pelvic organ prolapse tend to mainly complain of discomfort, some kind of pressure in the pelvis. Unfortunately, some of them even feel the organ falling out, for example, of the vagina. Symptoms that they have associated with this prolapse tend to be referable to whatever organs are involved. Well, the ultrasound equipment, which can be used for this examination, include a curvilinear 3D transducer, and in my laboratory, we use a relatively low-frequency transducer, which is between 4 and 2 megahertz. One can also use, as Dr. Pretorius noted, a 3D endovaginal transducer, and in some laboratories, a combination of both of these transducers is used. Any examination protocol should include not only documenting the organs at rest, but they should also be documented with the patient performing Kegel and valsalva maneuvers. As noted again by Dr. Pretorius, 3D imaging is really important in this evaluation. And the reason for that is because it's that transverse or oblique coronal image, which is really the key image that we need in order to evaluate the type of surgery which has been done in these patients. Cine clips are also very useful, and this is also because some of the disorders really aren't seen until the patient performs valsalva, or some of the problems get worse with valsalva. So I really encourage you, if you're planning to do this type of examination, to get the kind of equipment you need that has both 3D imaging as well as CD clip documentation. I'm now going to be reviewing the female pelvis, just the normal anatomy. So the image on your left is a schematic of the female pelvis, and the image on your right is an ultrasound, transperineal ultrasound in the parasagittal view. And so this ultrasound is performed along this yellow dotted line. And what you see here is the symphysis anteriorly with shadowing, the urethra, which leads to this bladder, and then just posterior to the urethra will be the vagina, and then posterior to that will be the air-filled rectum. Again, I want to emphasize a lot of your diagnostic imaging is going to hang on that 3D image. And so one of the key images is the transverse or oblique coronal view, which you see here. I'm comparing it to the comparable CT scan. And so this is the reconstructed ultrasound image showing the symphysis, the urethra, vagina, and rectum. As I stated earlier, there are two presentations for pelvic floor disorders, and it's important to be aware of this, so when you're talking with the patient, you can anticipate what kind of treatment they have either had or will have. If a patient comes in with stress urinary incontinence, then most likely, if they've had treatment, it's been some type of suburethral sling. And there are two types of suburethral slings that are performed, that of a retropubic and transobturator tape sling, and the material used looks just like this. In pelvic organ prolapse, because the organ involved generally requires a broader area of support, now you're talking about material which is what we call mesh material, which is this here. And the shape of that mesh depends on the organ involved. This mesh is extremely thin. If you actually feel it, it feels like one layer of gauze. So at this point, I'd now like to turn to the sonographic appearance of these surgical materials. And first of all, I'm going to describe the midurethral sling. Well, both types of slings look the same on the parasagittal exam. So again, this is the midline parasagittal exam with the symphysis anteriorly, the urethra. The vagina has some air, so it's a little bit bright. The rectum is back here. And between the urethra and the vagina, you see there's a short echogenic line. And that is a suburethral sling. And as I said, both types of slings look the same on the parasagittal view. So that's why the 3D image is so critical. Without the 3D image, you don't know what kind of sling you're looking at. So the images on your left are schematics of the pelvis, and this is a retropubic tape sling. And this particular sling is located in a fairly tight U around the bladder. And so this is the white line that you see in the schematic. And on the transverse or oblique coronal view, what you see here is, again, let me orient you, symphysis, ureter, vagina, and here you see this sort of U-shaped echogenic material that is a retropubic sling. Now this is in contrast to the other type of sling, that is a transobturator sling. Because the arms of the transobturator sling go through the obturator foramina, the shape of this sling is more horizontal compared to the other sling. And so again, it's that transverse or oblique coronal view which is going to give you that information. So again, here's the anatomic information. Here's symphysis, ureter, vagina's back here. And between the ureter and vagina, you see that this echogenic material is relatively horizontal, and that is the sign of a transobturator sling. Both types of slings are very well seen sonographically. They both appear as echogenic lines. Well, now let me turn to the mesh. What does mesh look like with ultrasound? Well, mesh, as I stated before, can be variable. It depends on what organ is being supported. And so in the old days, like about 10 to 15 years ago, surgeons would just take this material and sort of cut it out themselves, sort of estimate what they need, cut it out, and then put it in the pelvis. However, more recently, we now have pre-cut kits, so surgeons can just fit it into the pelvis, and the shape of the kits just depend on what it is they're trying to treat. The image on your left, again, is a schematic just showing a kind of way that this particular mesh fits behind the organs, and you can see here tends to be flat and very, very thin. Well, in ultrasound, mesh has multiple ways that it can present. And so these are the major ways that one can see or identify mesh. It can appear as a short echogenic line, very similar to the suburethral sling, except in this case, generally it's not in the position of the suburethral sling. It can be a long echogenic line, multiple short linear echogenic lines, or it can be a dash dot dash echogenic pattern. So the image here just demonstrates the appearance of both a sling and mesh. And again, here is the symphysis anteriorly, bladder, and then the urethra is right here, and posterior to the urethra is the suburethral sling. Here is the vagina, which has air, and then posterior to the vagina is mesh, because this patient's had a prior vaginal prolapse. And here you see this is the pattern of more of multiple short linear lines. Well, on the other view, the oblique coronal or transverse view, mesh is very difficult to identify. As I stated earlier, it's very, very thin. So because it's so subtle, you have to be careful in terms of how you reconstruct your image. And obviously, in this case, it's useful to have an experienced person doing that reconstruction. In this case, the mesh just looks like a heterogeneous, predominantly slightly more echogenic area compared to the surrounding tissues. Well, now I'd like to turn to what are the types of findings you may see if a patient comes in and they're complaining of some kind of pelvic floor symptom. First of all, many people, actually the most common symptoms we tend to see are of the bladder. And so if a person has problems with difficulty voiding or pelvic pressure, if a patient has difficulty voiding, one of the most common findings we see is that of a cystocele. And a cystocele is merely a weakness in the bladder wall. And so what we see here is the bladder wall pooches inferiorly and posteriorly. And this is the resting view. But remember I said that on our exams we always do both a Kegel and valsalva. Well, on the valsalva, here you see the cystocele increases greatly in size. And so cystoceles are very common, and it's something that you certainly should be able to easily recognize. Another finding that you may see if a woman has urinary symptoms is that of bladder funneling. Now, in this particular case, in the resting view, things look pretty good. Bladder looks fine. There's no particular cystocele here. Here's the urethra, vagina, rectum. This person already has a sling placed. However, with valsalva, notice some of the urine backtracks or goes forward into the urethra. And so this V-shaped area of fluid, that is what is called funneling. Transperineal ultrasound also, obviously, can see structural abnormalities of the female pelvis. And in this particular case, the patient had bladder infections. And when we looked at the pelvis, what we noted immediately is behind the urethra, there was a mass which contained a calcified structure. And this appearance was consistent with a urethral diverticulum. Later on, the patient also had a CT, which just confirmed what we saw. Well, now I'd like to turn to the problem of prolapse. And actually, uterine prolapse is something that is really a clinical diagnosis. On a physical exam, a gynecologist will see that the cervix is in abnormal position. However, if the patient hasn't had a gynecologic exam, or if there is a prolapse, it is important for you at least to be able to recognize it. And so this is a case of prolapse. Here is the bladder. This is the base of the bladder. Here is the urethra. And in this case, notice that the cervix is much further inferior. So this is the perineal surface, much closer to the perineum compared to the bladder base. So this is an obvious case of uterine prolapse. On every single case, whether or not the patient has rectal symptoms, we always look at the rectum. And so in this particular case, again, I'm going to show you, this is the symphysis, this is the ureter, vagina, and in the rectum, notice this is the anterior wall, and there's a little bulge here on the resting view. This is the posterior wall of the rectum. And with valsalva, that bulge increases. And so this is a rectocele. And rectoceles are very easy to see, and generally they do increase, again, with valsalva. Well, in my practice, actually, the vast majority of patients are coming to us because they have some kind of possible postoperative complication. And unfortunately, this group of patients has received a great deal of publicity in the press and in the legal societies. So actually, in our area, they're at law firms that advertise for patients. So it's certainly an area that you should be very, very familiar with and, be very careful whenever you do these exams. Now, the symptoms that one can have after surgery that might indicate a complication are listed on this slide. And the most common symptom is that of pain. You can see about a third of the patients that have complications have pain. Other symptoms include bleeding, dyspareunia, urinary problems, and neuromuscular or bowel problems. The type of imaging findings that you will see or may see with ultrasound, again, are listed here on this slide, and I'll be showing you some examples. They include erosion or perforation of the sling or mesh into the pelvic organs, and this is the most common complication. It is about 35% of all complications that one sees. Other complications include fragmentation or displacement of the sling or mesh, fistula formation, infection, scarring, or recurrence of prolapse or incontinence. So this is a 73-year-old woman who 5 years prior had had surgery and now comes back with multiple urinary tract infections. And on her exam, it's clear she's got an abnormal bladder because she has a cystocele, large cystocele. But she also has something else. Here is this echogenic material extending into the bladder, and this, unfortunately, is a fragment of her previous mesh, which had been placed, and so this is also probably the reason for her symptoms. So noted that this is the most common complication one sees with postoperative in the postoperative area. The second woman had very similar presentation with pelvic pain after surgery. In her case, this is an oblique coronal exam. This is the bladder, and on the right side of the bladder, notice we see multiple short echogenic lines. And so what these are fragments from her prior vaginal sling and mesh. And even though these fragments haven't perforated an organ, they commonly cause inflammatory response, especially at these edges, and so are associated with pain. So it is important that if you see fragmentation, that you tell the urologist this. This next patient had urinary leakage, and when we did the transperineal exam, we noted that there was a suburethral sling. This is the urethra, the vagina just behind. And when we looked at it closer, so this is a close-up shot, we noticed that unfortunately this sling had actually perforated the urethra into the vagina, and so had caused a urethral-vaginal fistula. So ultrasound, because we see this synthetic material so well, is a great way to be able to problem solve and tell a urologist if there are going to be any problems that they need to try to adjust. This next patient actually came in primarily with urinary problems, and she does have urinary problems. In other words, on her bladder, you notice that she forms a little cystocele with valsalva. However, because of the appearance of the rectum, I then started asking her about her bowel movements. And immediately she said, oh yes, after she had her surgery, she started having real problems being able to evacuate her bowels. And the reason I asked that is because on the resting view, this is what you see. So here's her anterior rectal wall, and notice that it angles down right here. And it turns out she'd had a previous rectocele repair as well as mesh surgery for her urinary issues. And with the valsalva, right at the area of the angulation, there is this little outpouching of the rectum, and so she has a small rectocele. And for her, that was significant because it changed the angle of the rectal canal such that it partially obstructed any kind of fecal material that might leave. And so that's the reason for her symptoms. Well, finally, I'd like to discuss the role of MR versus ultrasound in pelvic floor disorders. All of us know that ultrasound is less expensive, painless, and very well tolerated. I mean, we don't have to worry about patients having claustrophobia. And ultrasound, furthermore, is excellent in identifying synthetic materials, much better than MR. MR studies which have been done in vivo show that these materials are very difficult to identify. Furthermore, ultrasound is better in identifying movement. So if you have some kind of dysmotility, as I've shown you in the slides, we're really an excellent way to be able to show that in real time. But MR definitely has a place in pelvic floor disorders, and what we found in our experience is these are the areas that we particularly like to do MR. Now, first of all, we find that MR is better in identifying abnormalities in the retropubic portion of the pelvis as well as anterior to the sacrum. Remember the symphysis? Whenever we look at the symphysis, there's always some shadowing posterior to the symphysis. So that area just posterior to the symphysis is very difficult for us to evaluate. Furthermore, anterior to the sacrum is just too deep. I mean, we just cannot see it. And so abnormalities then, which are in those particular regions, are much better identified by MR. MR also is better identified if the patient has had human tissue types of materials used for their sling. Because what happens to us is if a patient has a human tissue sling, it blends in with the rest of the tissues of the pelvis, so we really don't define it as well, whereas MR is able to define it much better. Next, MR is better able to, or at least is prettier, let me put it that way. Clinicians really like MR in being able to show them the low position of organs in the pelvis. And the reason is because it's got this wide field of view. You can see the bony landmarks, and it's something that they can sort of visualize well, and I'll show you an image of that. And then finally, there are some surgical complications which are very subtle for ultrasound, which are probably better identified by MRI. Well, these images, these schematic images, are just to emphasize some of the areas which are relatively blind to ultrasound. And so in this particular image, the black area is where mesh would be placed for a sacrocolpoplexy. And notice that the mesh is placed way up high on the sacrum, and this area, frankly, we cannot see. I mean, this is not an area we can see. We can visualize this region well, but when it comes to anything abnormal up here, we have to defer to MR. The other areas I stated before is right behind the symphysis because many times there's just too much shadowing in that area. Well, this is an example of a 48-year-old who was transferred to our institution after she just had an iliotibial band, a human iliotibial band sling placed. And unfortunately, after it was placed in an outside institution, the patient stopped being able to urinate. And so this is an MR showing her pelvis, and you notice this low intensity band, that's the iliotibial sling. And then on the parasagittal exam, this is the level of the sling, and notice this is the ureter, and it angulates very sharply where that sling was placed. And so it's very clear that in this particular case, the problem the patient has is due to a sling which was placed too tightly. This image is just to show why a lot of urologists really like MR. Now, we can do measurements, and certainly, from our point of view, we can definitely say and tell a urologist without a doubt which organs are abnormally low. However, this picture, for many people, is just worth more. So this is the pubococcygeal line from the inferior symphysis to the sacrum, and on the rest, things don't look too badly, but with valsalva, notice that there's quite a bit of dropping of the pelvic organs. So, this is a very pretty image. Well, the next case is a woman who has pelvic pain, and on her MR, she had a small amount of fluid in her groin, and that tracked back to the pelvis, and there's not much fluid in the pelvis. And this patient had a urethral sling. Now, for ultrasound, we could find this area in the groin. That's not a problem. And we can even see a little track. The problem is here. If there isn't much fluid around the device, around the synthetic material, it's hard for us to define whether it's actually infected. And so MR then, it can be very useful in these more subtle infection cases. In this particular case, it's similar, except that this particular sling, the sacrococciplex sling, is one which we, as I stated earlier, have a difficult time visualizing. So in this particular case, we see that there's increased intensity of the sling in the pelvis. It tracks up the anterior aspect of the sacrum. And as I stated, this is an area which we just don't see well. And so again, this is an area where MR is better than us. Well, in conclusion, I hope I've shown that ultrasound, transperineal ultrasound, is an excellent method to evaluate patients with either symptoms of pelvic floor dysfunction or signs of complications. The optimal ultrasound evaluation does include, besides 2D ultrasound, 3D ultrasound, and sonography. And finally, MR is complementary to ultrasound in certain circumstances, such as slings composed of human tissues, low position of pelvic floor, and certain subtle surgical complications. Thank you.